My name is Winston Ho. I'm Assistant Professor of Neurosurgery at University of Texas, presenting the slides on Chapter 223 of Yeoman and Wynn Neurologic Surgery, titled Hydrocephalus in Children, Etiology and Overall Management, on behalf of myself and senior author Dr. John Kessel, Professor of Neurosurgery at University of Utah. Hydrocephalus is the most commonly treated condition by pediatric neurosurgeons, as illustrated in the breakdown of cases seen in an average pediatric neurosurgical practice in the left pie chart. But hydrocephalus also represents a significant burden on the healthcare system. In a hospital utilization analysis published in 2008, it is estimated that in the United States, every year there are 40,000 hydrocephalus-related admissions and approximately 400,000 hospital days of stays. It incurs between $1.4 to $2 billion of hospital charges, representing 3.1% of all pediatric hospital charges. Hydrocephalus can broadly be categorized into congenital and acquired. Congenital hydrocephalus most commonly are represented by aqueductal stenosis or myelomeningocele, Danny-Walker malformation, and malformation of other brain development. Acquired hydrocephalus most commonly are post-hemorrhagic, post-infectious, or hydrocephalus related to brain tumors. The incidence and etiology of hydrocephalus varies by geography. In a meta-analysis performed in 2018, it's been estimated the annual incidence of hydrocephalus ranges from 120 to 500 per 100,000 new births, accounting for an annual number of about 330,000 new cases worldwide. However, most of the new diagnosis of hydrocephalus occurs in low-income countries, including sub-Saharan Africa and South America, accounting for about 318,000 new cases. In high-income countries, including Canada, United States, and Western Europe, there's only about 12,000 cases a year. The etiology of hydrocephalus also differs significantly between high and low income countries. In North America, post-hemorrhagic hydrocephalus of prematurity is the most common cause, whereas post-infectious and other congenital causes predominate in the developing world. There is evidence to suggest that the incidence of hydrocephalus is decreasing in North America. In a survey performed in the 1990s, the number of first shunt insertions for children under the age of 17 has substantially decreased over the decade. It was felt that that is due to a combination of factors, including the increased use of prenatal folic acid to decrease the incidence of myelomeningocele, the advent of fetal surgery to close myelomeningocele in utero to decrease the need for VP shunting. Also, the decreased incidence of intraventricular hemorrhage due to improved management of prematurity, as well as determination of pregnancy based on antenatal screenings of fetus with a significant malformation. The decision to treat hydrocephalus is a critical one that's faced by pediatric neurosurgeon frequently. Unlike in an acute adult setting, hydrocephalus in children often is not a medical emergency. The indication to treat includes progressive signs, including increasing head size that crosses growth percentile, or radiographic finding of progressive ventricular size that often can be quantified using metrics such as the front occipital horn ratio shown on the right. Also, progressive symptoms related to increased intracranial pressure. It is very rare that one would have to treat hydrocephalus on first evaluation. It is also important to be aware and cognizant that the decision to treat hydrocephalus result in a lifetime commitment for both the patient and the parents. Symptoms of hydrocephalus varies based on age of presentation. In young babies with large open fontanelle, increased irritability and vomiting are common.
On physical exam, bulging fontanelle and split sutures are prominent features. The assessment of bulging fontanelle and split sutures have been shown to be reliable exam features with high inter-rater reliability. Other features include sunsetting and apnea. In older children, headaches become more of a common features when the skull matures and the fontanelle closes. Also, a regression of developmental milestones could be an important sign. The decision to treat or to observe is the first critical decision point. Once you make the decision to treat hydrocephalus, the next decision is what to treat it with. Ventricular peritoneal shunting is traditionally been the tried and true method for decades. And more recently, endoscopic third ventriculostomy with or without choroid plexus cauterization have increasingly been used in subset of patients with hydrocephalus to treat without permanent shunt placement. Once a decision has been made to place a ventricular peritoneal shunt, a number of variables can be considered. Primarily, what kind of valve one would like to put in. There is a gamut of choices that ranges from pressure or flow regulated valves or programmable valves where one could remotely change the amount of spinal fluid drainage based on a different pressure differential, and whether to place anti-siphon device together with the valve to prevent overshunting. A full discussion of the nuances of different valve options is beyond the scope of this lecture. Another variable to consider is what kind of tubing to use. Standard elastic tubing versus silver impregnated tubing versus antibiotic impregnated catheters. And also insertion location and techniques, whether one would like to choose a frontal entry point or occipital entry point, and whether to use adjuncts such as ultrasound guided or stereotaxis guided ventricular catheter placement as opposed to freehand techniques. We'll go over some of the recent data that would help guide some of the choices in VP shunt placement. A recent Lancet publication in 2019 specifically addressed the question of what kind of shunt tubing should be used to decrease VP shunt infection. This is performed in a multi-center fashion in the United Kingdom, where over 3,000 patients were randomized between 3 groups for initial VP shunt placement using standard shunt tubing, silver impregnated shunt tubing, or antibiotic impregnated shunt tubing, with at least 22 months of follow-up and infection rate as a primary endpoint. They have shown quite convincingly that antibiotic impregnated shunt tubing significantly reduced the risk of shunt infection from 6% in the other 2 groups to 2%. Importantly, they also did an economic analysis to justify a higher upfront cost with antibiotic shunt tubing with savings from decreased shunt infection. Whether image guidance, whether ultrasound or stereotaxis could improve shunt survival has been an often debated subject. A study published in 2013 comparing the use of freehand technique and ultrasound guidance failed to demonstrate any significant benefit in terms of shunt survival with ultrasound guidance. A meta-analysis published more recently in analyzing a number of studies demonstrate a very weak benefit of image guidance in terms of accuracy of ventricular catheter placement, but cannot draw any conclusion due to study heterogeneity in terms of whether image guidance could affect shunt survival. However, the choice of whether to use image guidance obviously needs to be individualized based on individual patient condition, especially, for example, in slit ventricles, where cannulating the catheter could be difficult in the absence of guidance, or surgeon level of comfort and training with these different adjunct techniques. As any practicing neurosurgeon, especially pediatric neurosurgeon, would attest to, shunt failure is a very common occurrence. Most natural history cohort, one included on the right side from ACRN cohort, published 2013, demonstrated that about 40% of shunt fails in the first year, and that failure rate continued to increase over time. In a large survey of patients in their early 30s who had shunt placed as a child, over 50% of them experienced at least 4 shunt revisions. About 10% of them experienced more than 3 shunt infections, and only 10% had no shunt revisions at all. In terms of recognizing VP shunt obstruction, one of the most valuable dictum has been to listen to the parents. Mom or dad who've been living with their child their whole life with a VP shunt are often very sensitive to how they present when their shunt fails. In older children who have multiple previous failure, they often present with very similar clinical features. In babies with VP shunts failure, they often present with similar clinical features, such as increasing head circumference, a full fontanelle, increasing irritability, vomiting, and lethargy. Other than VP shunt obstruction, shunt infection is the other major morbidity of VP shunting. It is important to recognize that most VP shunt infection occurs within the first 6 months of either initial shunt placement or revision. When a child presents with a shunt and fever, one would always have to look for an alternative explanation first. In the absence of a better explanation of the fever, and if the shunt is placed within the first 3 to 6 months, it is very reasonable to perform a shunt tap to rule out a shunt infection. If, however, the shunt was revised or placed more than 6 months ago, culturing other sources is a very reasonable strategy. It is also important to note that children with spina bifida often present with headaches, vomiting, with or without fever, mimicking symptoms similar to shunt failure when they present with a UTI. So it's very important to check a urine culture or UA in a spina bifida patient who present with those symptoms. An alternative to VP shunting treatment of hydrocephalus is endoscopic third ventriculostomy, which involves the procedure of creating an alternative pathway for spinal fluid to flow through the floor of the third ventricle into the prepontine cistern. It has the obvious appeal that you do not require to place permanent tubing, as in the case of VP shunts. However, not all hydrocephalus patients are good candidates for ETV. A group in Toronto formulated a ETV success score to predict the chances of success after ETV procedure. One of the most important predictors of success is the age of patient. Patients who are younger than 6 months of age have a significantly lower chance of success after ETV. The second important factor is etiology of hydrocephalus. The most favorable etiologies include aqueductal stenosis and tectal tumors, in which there is a physical obstruction of the flow of spinal fluid in the ventricular system. The least favorable etiology includes post-infectious hydrocephalus, in which the inflammation and scarring likely result in obstruction at the level of absorption of spinal fluid. The third factor is whether a patient had a previous shunt. A history of a VP shunt is an unfavorable factor for success of ETV. The ETV success score is applied by adding up the scores of these three different factors, and the total score is approximately the percentage success at 6 months of whether you can be shunt free or not. This ETV success score is derived from a pediatric population and is validated in a number of different other pediatric cohorts. However, the applicability in extrapolating to adult population is less successful. In this same study, the authors stratified the patients into 3 categories based on the ETV success score: high success score of greater than 80, moderate 50 to 70, and lowest less than 40. And they compared the cumulative treatment survival between ETV and matched patients with shunt placement. And what they found is that in the group with high ETV success score, throughout the course of the follow-up up to 4 years, their cumulative survival is superior to shunting. In the moderate group, the initial failure rate in ETV is higher, but beyond 2 years, as the failure rate of shunt continued to increase, the rate of success of ETV appears to converge with the success rate of shunting. And for the group with low ETV success score, the success rate of ETV is significantly lower than VP shunt until up to 4 years, where it seems the success rate appear to converge. The ETV success score therefore provide a rough guideline to help consult patients and to guide the surgeons in deciding whether VP shunting or ETV could be a better option. This slide on the left illustrates the intraoperative endoscopic images showing the steps of creating a third ventriculostomy in a patient with aqueductal stenosis demonstrated on the right MRI image, where you can see a disproportionately enlarged third ventricle and lateral ventricle and a small fourth ventricle with obvious obstruction at the level of the aqueduct. There's also bowing of the floor of the third ventricle. On the left endoscopic images, left upper picture showed the right frontal horn, visualizing the foramen Monroe. You can orient yourself by the orientation of the septal vein medially that converges with the thalamotrial vein that directs laterally in the area of where the choroid plexus is in the posterior edge of the foramen Monroe. The right upper image showed a neuroballoon inserted into a hole that's already created for the third ventricle. The inflation of neuroballoon create a larger fenestration to ensure sustained patency of the third ventriculostomy. The left lower image showed the final ETV. You can note that the fenestration is situated between the pair of mammillary bodies posteriorly and the infundibular recess anteriorly. The endoscope was then inserted through the ostomy and visualizing the prepontine cistern with the liliquous membrane, as well as the naked basal artery on the right lower corner. As mentioned in the previous slide, the age of treatment is the most important factor in determining ETV success. Infants that are younger than 1 year old is noted to have very poor success rate with ETV alone. Based on the work done by Dr. Benjamin Wharf in Uganda, where he performed, in addition to ETV, choroid plexus cauterization, have reported a high success rate in patients with post-infectious hydrocephalus. In fact, in a 5-year follow-up, he demonstrated that ETV-CPC have similar cumulative survival as shunting. Whether success of treating post-infectious hydrocephalus could be translated into the North American cohort, where the etiologies of hydrocephalus is mostly post-hemorrhagic, as well as aqueductal stenosis, have been questioned. So Dr. Warf in 2014 reported his single institutional experience from Boston Children's using ETV-CPC in infants younger than 6 months with various etiologies, and have shown a similar rate of success to the cohort in Africa, reaching around a 60% rate of success over the long term. However, the high success rate of ETV-CPC in infants reported in a single institutional study was not reproduced in multi-center prospective study performed by the HCRN. The long-term ETV success rate is closer to 40% in this study. And when compared to match VP shunt controls, the success is significantly lower. The difference in the result could be attributed to variation of the technical nuances of the performance of ETV-CPC, or the learning curve associated with performing this type of procedures. A larger multi-center randomized controlled trial will likely be needed to further illustrate whether the ETV-CPC success rate could be applicable in a wider population. One of the critical unanswered questions of ETV-CPC is how the final ventricular size affect neurocognitive outcome in the long run. It is widely recognized that VP shunt result in significantly greater reduction in CSF volume and a high proportion of patients with increased brain growth as measured by brain volume imaging, as illustrated in the pictures in the bottom. You can see in the middle figure, VP shunt placed 12 months later resulted in a significantly smaller ventricle compared to ETV-CPC, in which the ventricles remain persistently enlarged even with smaller than baseline, and in the absence of increased obvious clinical symptoms, increased cranial pressure. Whether the larger baseline ventricles and smaller brain volume result in a poor cognitive development is a largely unanswered question. In a paper published by Dr. Warf's group in 2017 New England Journal of Medicine, he tried to answer this question using a randomized control trial of Uganda infants with post-infectious hydrocephalus, and randomizing them between ETV-CPC and VP shunt, and using cognitive outcome at 12 months as the primary endpoint. In this smaller study, the overall development outcome was not changed, but their baseline is generally poor to begin with. Whether this could be extrapolated to North American population with different etiology of hydrocephalus is largely unclear at this time. A large randomized control trial by the HCRN is currently underway to address this question.